Whenever I talk about renal tubular acidosis, I'm always talking about normal anionic gap metabolic acidosis. So you also hear HAGMA, high anionic gap metabolic acidosis in one renal disease, which is nothing but chronic renal failure. So please understand, when it's chronic renal failure or uremic renal failure, it is high anionic gap metabolic acidosis. But when it is renal tubular acidosis, it is normal anionic gap metabolic acidosis. Uh, you know that renal tubular acidosis can be 1, 2, and 4. 4 is very different from 1 and 2. The confusion lies between 1 and 2. So 4, please remember, is always going to come with an increased levels of potassium, that is hyperkalemia. Why does this happen? First, you need to understand a little bit of physiology basis. Is that afferent arteriole, okay, it can either constrict or it can either dilate. You all know that if it constricts, if the afferent arteriole it constricts, it will decrease the GFR. But if it dilates, it will increase the GFR. Who is responsible for dilating the afferent arteriole? It is PGI2. And who is responsible for constriction of the afferent arteriole? It is adenosine. So please understand, if I increase PGI2, I increase my GFR. If I increase my adenosine, I decrease my GFR. So if I'm giving NSAIDs to any patient, his PGI2 level is going to decrease, so his GFR will also decrease. So any patient taking non-steroidal anti-inflammatory drugs will have decreased GFR over long term, obviously. Another thing is that efferent arteriole. Who is constricting the efferent arteriole? The answer is angiotensin 2. So this is going to increase the GFR. So why did I say all of this? Is that because in type 4 RTA, there is thickening in the pathophysiology. It happens in people who have diabetes over long term. So because in them there is thickening of the efferent arteriole. Because of such massive thickening of the efferent arteriole, there is an increase in the renal perfusion, there is an increase in the GFR, there is decreased delivery of sodium in the distal convoluted tubule. The body wants to decrease this increased GFR. How will the body decrease this increase in the GFR is what we'll see. Firstly, I told you in the pathophysiology that there is constriction of the efferent arteriole. We do not want this constriction. We want this efferent arteriole to dilate. How can you do this? Simple, by decreasing the angiotensin level. In an attempt to do so, even your aldosterone level is going to decrease. This is very important. The aldosterone level decreases. Why does it decrease? Is because we want to dilate the efferent arteriole. How can we dilate the efferent arteriole? By decreasing the angiotensin 2. Second point is how we can decrease the GFR is by constriction of this afferent arteriole. How can we constrict this afferent arteriole? Decrease something that is responsible for maintaining the patency of this afferent arteriole, and the answer is PGI2. So please remember, in type 4 renal tubular acidosis, the pathophysiology goes something like there is constriction of efferent arteriole. Because of this constriction of efferent arteriole, there is an increase in the GFR. The body wants to decrease this GFR, right? This increased GFR. So it does two things. It decreases the PGI2 and it decreases the aldosterone levels. Because there is a decrease in the aldosterone levels, there is an increase in the potassium levels. Mostly, I'm not saying always, mostly when the aldosterone level increases, the potassium level decreases, and when the aldosterone level decreases, the potassium level increases. It follows an inverse relationship. It will help you solve a lot of MCQs. Usually, why does this happen? You all must be knowing that aldosterone acts via the ENaC channels, right? ENaC channels pull out the sodium from the urine, right? And only when this happens is you can throw out the K plus and the H plus in the urine. So if I have decreased levels of aldosterone, my ENaC channels are not functioning that well. If I cannot retain Na plus from the urine, I cannot throw out H plus and K plus into the urine as well. So if due to some reasons I have aldosterone resistance, right, or a decrease in the aldosterone levels itself, or some malfunctioning of the ENaC channels, right, all of these problems can arise, right? So few other important points about type 4 renal tubular acidosis. It happens in diabetics. Second point is that it will come with an increased potassium levels. Third point, why does this happen, is because of a decreased aldosterone level, right? Or an aldosterone resistance also you can cause it. The fourth point is that the fractional excretion of the bicarbonate in the urine is going to be less than 3%. and your pH of the urine can also be less than 5.5. Why are these two important points? Is because these are problems with renal tubular acidosis type 1 and type 2, which is not seen in type 4. So there is no problem with secreting the H plus into the urine, right? Because of which, in the distal convoluted tubule, because of which the urine pH can be maintained at 5.5 or less than 5.5. And the bicarbonate is nicely reabsorbed in the proximal convoluted tubule without any problem, because of which the fractional excretion of that found in the urine is less than 3%. Then another very important point, it can also be seen with any drugs that will cause aldosterone resistance. One drugs which causes aldosterone resistance is heparin, and obviously ARBs and ACE inhibitors, or it can also be seen with calcineurin inhibitors. As you all know, if you can block the ENaC channel by a drug, it will cause the same type 4 renal tubular acidosis. Amiodarone is one drug which can block the ENaC channels. So this is something about type 4 renal tubular acidosis and understanding the pathophysiology behind it. Just a little offbeat, when you talk about hypokalemia, you can talk about three inherited conditions or genetic conditions, Little Barter's and Gentleman syndrome. These all three will come with hypokalemia, right? Now, in Little syndrome, what the problem is, like I told you, whenever there is an aldosterone increase or decrease, potassium levels are going to be inverse. This is one place where that is not true. Why? Is because there is hyperfunctioning of the ENaC channels. For some reason, ENaC channels are functioning more than they should. The body is retaining more sodium than it should, and it is throwing out more H plus and more K plus. Because of this, it leads to alkalosis plus hypokalemia. And please note, in this condition, there is hyperfunctioning of the ENaC channels without an increase in the aldosterone levels. Why? Because there is a mutation at the receptor level itself, right? So even though in this condition the aldosterone level is low, still the potassium level is also low. Why? Because there is a mutation in the ENaC channel. Usually, if you go to see, in most of the diseases, aldosterone and potassium follow an inverse course, like I said. This is one disease where that is not true, where a decrease in the aldosterone will also cause a decrease in the potassium level. And Little syndrome will come with hypertension. Why? Because I told you the body is retaining more sodium than it should by hyperfunctioning the ENaC channels. So Little syndrome ka hint in the exam will be hypertension, right? Hypertension, hypokalemia, alkalosis, right? And when you look at Barter's versus Gitelman, Barter's is nothing but somewhat like a patient who is on taking long-term loop diuretics. There is a defect in the ascending loop of Henle in the Na plus K plus 2 Cl minus channels. I hope this is clear. And Gitelman's is due to Na plus Cl minus channels in the distal convoluted tubule. Both will come with hypokalemia. Both will present with alkalosis. So how do you distinguish between the two? One very important point which I remembered for the exams is Barter's syndrome comes with nephrocalcinosis. The patient will have a history of kidney stones, but in Gitelman there will be no such thing. Another important point that may help you in the exam is that Gitelman syndrome will come with a decrease in the serum levels of magnesium. Why? Because there'll be more magnesium thrown out in the urine. So one peculiar point of everything, Barter's syndrome comes with nephrocalcinosis. Gitelman syndrome comes with a decrease in the serum magnesium levels, and Little syndrome comes with hypertension. Whereas these two conditions, Barter's and Gitelman syndrome, will not come with hypertension at all. The moment you see hypertension in your exam, Barter's or Gitelman will not be the answer. Little syndrome is what can be the answer. Remember, all three will come with hypokalemia, decrease in the potassium levels. Whenever they talk about hyperkalemia, never answer these three in your exam, right? I also told you the exception of aldosterone and hypokalemia being directly related in this condition. So this is all about type 4 renal tubular acidosis and Barter's, Gitelman and Little syndrome. Now we can move on to type 1 and type 2 renal tubular acidosis.